Hey, okay. Um,
Hey, go ahead and get started.
yep.
Hey, thank you everyone for joining. I am Ehab Hussein, and I'm the Chief of Pulmonary and Critical Care Medicine at the Mount Carmel Health System. And we're about to talk about a topic that we are passionate about. We are passionate about lung cancer prevention, lung cancer diagnosis and treatment. Um, I'll introduce my partner, Dr. Shri. He joined us within the past year, and he is a pulmonologist and part of our team, and is going to talk about lung cancer. I will turn over the presentation to him, and we'll go from there.
Thanks, Dr. Hussein. Appreciate it. And thanks all for joining us on this lunch hour. And so, again, my name is Dr. Shri. The topic for today is just to kind of go over kind of basics of lung cancer and kind of lung cancer screening and kind of preventative things that we can all do that kind of hopefully reduce the burden of this disease. So just a little bit about myself. I'm originally from Wisconsin. I did my medical school in Philadelphia at Drexel. Went back home to Wisconsin to do my residency there. And currently I'm certified in both lung medicine and also ICU medicine in the hospital. And my clinic is in Mount Carmel, near Mount Carmel East Hospital at Taylor Station. And so the agenda today, is, at least from the presentation perspective, the goal of it is to kind of talk for about 15, 20 minutes, and we leave you guys about 10 minutes for questions. If you have any questions, please feel free to put it in the chat, and we'll try to answer as many as we can. If we see a lot of questions, I'll try to cut the presentation short because I want to be able to answer all of your questions. But in terms of the presentation, what we're going to try to talk about here is what's lung cancer screening, both the why, who, what, and where, the basics of a lung nodule, what a lung nodule is and what we look for, and cancer risk and mitigation and management as well. So it's a lot to go through, but hopefully we'll power through. So lung cancer screening. So before we talk about lung cancer screening, it's important to talk about what the lungs are. And so they're the main organs in your chest that's responsible for breathing. We both have a right lung and a left lung. And the parts of the lung that are there are airways, blood vessels, and lymph nodes that are kind of branching out from the main airway, which is the trachea, which is right here, and just branching out like branches of a tree all the way to the end. And you can imagine that anytime there's an abnormality in the lungs, it'll show up on a CAT scan, and it can present as a lung nodule, which we may have to figure out what it is. And the problem could be any one of these things, either a problem in the airway, a problem in the blood vessel, or a problem in the lymph node. Quickly, some signs and symptoms of lung cancer. So when they looked at people who have had lung cancer and they asked them what symptoms they had, these are the main symptoms they had. Most of the time they've had a chronic cough, at least half have had a chronic cough for at least a few months. A lot of them had weight loss. Significant minority have had shortness of breath. When we talk about lung cancer, we always think about coughing up blood, but actually it happens, but it's not as common as we think. And what's most important I want to emphasize is that a significant minority of patients don't have any symptoms of all lung cancer, but 20 to 30% of people don't have any symptoms at all. So why is this important? Is this is the why we want to emphasize lung cancer screening, because even if you don't have symptoms, if you have high risks of developing lung cancer, which we'll talk about, it's important to catch it early so we can treat it early and hopefully cure people of lung cancer. And so this data and these pictures are actually from the American Lung Association, where they actually look at data from each state in the country and kind of compare it. And so these are data in Ohio. And so the rates of lung cancer is about 65 per 100,000 people, which actually is a pretty significant amount. You can imagine there's millions of people in Ohio. And so there's probably hundreds of thousands of new cases of lung cancer per year. And the 5-year survival rate at time of diagnosis is pretty low. It's about 24%. And you can tell on the right-hand side, all of our data compared to the rest of the country. And the things I wanted to highlight is, although we do pretty good in terms of screening for lung cancer, we have a lot of lung cancer compared to the rest of the country, and we smoke a lot. And so that means we're kind of a higher risk population that can develop it. The picture in the center of the slide just kind of emphasizes that the earlier you catch the disease, the more likely you are going to survive. And that's why it's really important to catch these things early. So again, we're only catching early stage cancer about a quarter of the time. Our goal should be much higher than that. And that's the premise of screening for lung cancer. And this is where we get the data from. Smarter people than me have kind of looked at this, and they found, and they compare people who got a CAT scan versus a chest X-ray to look for lung cancer. And these were the people they looked at, people ages of 55 to 74. They smoked for 30 years, and they either were current smokers or quit in the past 15 years. And they found that the chances of dying of lung cancer, if they got a CT scan every year for these patients, was reduced to about 20%. You need to screen about 320 people to reduce one death. Why I put that number is, we all talk about mammograms and everybody has to get their mammogram every year. The rates of preventing breast cancer actually is a much lower. You have to screen 600 people about before reducing one death for breast cancer. So the power of lung cancer screening is a lot, and we can do a lot of good by emphasizing this. So who should get lung cancer screening? So obviously smokers and ages 55 to 74, but also there are other things. Occupational exposure, specifically things if you're exposed to any of these things, arsenic, asbestos, nickel, beryllium, cadmium, all these heavy metals, coal, especially in this area. Silica, so what is silica? It's like things like sandblasting or working with granite or stone, diesel. And for people who have homes, it's radon. You know, we always get our radon detected at home. It does slightly increase your risk for lung cancer. It's a bit controversial, but it does. We do recommend you check your homes for it. And if it's elevated and you have these other risk factors, you should talk to your primary care physician about lung cancer screening. And obviously, if you have family or personal history of lung cancer. So again, to summarize, which I think this is important, because if you fall into any of these categories, you should definitely ask either your primary care provider or ask to see your pulmonologist to see if you would be a candidate for lung cancer screening. So these are men and women aged 55 to 74, 30 years of smoking, current smokers, and those are quit in the past 15 years. So people who have those other risk factors of cancer, which we've talked about, people who are able to undergo treatment, and patient preference. This is where you need to talk with your doctor about and see if they find something, would you want to go forward with treatment for lung cancer? Some people do, some people don't, but this is where like patient preference and discussions that need to be had. So how do we do this? There's three main modalities, but really the main one we do is what's called a low dose CT. Basically, it's sort of a low resolution CT. a CAT scan of your chest. Then we can get a regular CT scan of the chest. You may have had these done when you go to the ER. And some people get things like PET scans, either after a low-dose CT or they happen to get it for some other reason. Just to quickly go over PET scans, because I talked to these, so a lot of my patients don't kind of understand what this test actually is. From your perspective as patients, it's basically the same thing as a CT, except they inject radio-labeled sugar into your body, and it kind of tells you which areas in the body are using more energy than usual. Now, hopefully everybody's brain lights up and other parts of your organs light up, but if things in your lung light up as much as your brain does, that means using a lot of energy, and it highlights abnormal areas. It doesn't necessarily mean you have cancer, but it's something you can't necessarily ignore. Next, let's briefly talk about what a lung nodule is. You might have heard this term in CAT scans or with other people. And all it is basically a roundish area in the lung, which is more dense than the surrounding lung. The lung is just a big bag of air. And so if there's something on a CAT scan, which is a little bit denser than air, like tissue or liquid, it'll show up as a whitish spot. And if it's kind of a roundish shape, it's called a lung nodule. And if it's less than 3 centimeters, it's a lung nodule. If it's greater than 3 centimeters, it's considered a lung mass. And so when you see that, yeah.
There's someone with hand raised. Is there a question from our attendees?
No.
No. Okay. So, go ahead. Sorry.
So when you get a CAT scan, or maybe you've seen, especially these days, you have my chart and you can see it on the report, evidence of a lung nodule. These are the questions that we ask, and these are the questions I think you should have in your mind when kind of evaluating how risky this lung nodule is. Is basically the size of the lung nodule, the type. There's what it looks like, where the lung nodule is, how it looks like, the borders of the lung nodule. Is it smooth? Is it irregular? Is there what's called calcification or calcium, or kind of almost like bone in the lung nodule or not? And if there's lymph nodes that are enlarged or not. All this sometimes can be gleaned from the report, but your doctor should be able to kind of look at this as well, or at least a pulmonologist should be able to look at this and help you answer some of these questions and then assess your risk of what that lung nodule is. And just to give you a kind of a comparison of, you see things on the report, millimeters. We're in the US. A lot of times we don't know what millimeters are. And so basically, if you see 5 millimeters is like a head of a push pin or a pencil eraser. A Cheerio is about 12 millimeters. A penny is about 20 millimeters, and a quarter is about 25 millimeters or 2.5 centimeters. 4 centimeters, which is like a lung mass, is about the size of a golf ball. So you can imagine 5 millimeters is pretty small, and that's commonly what we see. And when we look at a CAT scan, I'll show you 2 examples. The picture on your left shows a small 5 millimeter nodule where the arrows are, and you can see it's kind of hard to look at unless you're sort of looking for it. And the one on the left, on the right, is almost like 2 to 3 centimeters. So it's to give you an idea of what a lung nodule looks like and sort of the different sizes. And then what we do is if I see a patient, as I look at the picture, I talk to the patient, assess the risk factors we've talked about, and then oftentimes we these days have a lot of risk calculators, and the one I use is the one called the Mayo Risk Score, which kind of we plugged in these values based on what it looks like, the size, if you smoke or not, etc., and it kind of spits out a risk of how risky this is for being a lung cancer or not. And based on that, we can talk about what the next management strategies would be. The other thing that briefly I wanted to talk about is, when we're talking about lung cancer screening, is there any other easy things we can do, or non-invasive tests like blood tests? And there are. This is one trial or study which they looked at a specific blood test that looked at lung cancer proteins. And what it kind of shows is it does tend to kind of reduce the risk of getting procedures done, but it kind of there's a low chance of misclassifying the lung nodules. So I think in the future, as these tests get better, I think this will be more prominent. For now, I think it kind of depends on each specific physician, their preference of using this or not. In general, the way you would use this is if patients who have kind of in that middle ground to kind of potentially reassure both the doctor and the patient. Management. So let's say you have a lung nodule and we've kind of calculated the risk. And this is basically what we do is once we kind of assess what your risk of cancer would be, these are the basic options. And this is kind of when I see a patient, what I kind of go through. And what it boils down to is that the lower risk you have of it being cancerous, the more likely we would just follow it with CAT scans. If it's really high risk, then you would consider either just resecting it with surgery or taking it out with surgery or doing a biopsy. If you're in the middle ground, that's where patient preference kind of comes in, where we kind of talk to you, see what your thoughts are. Some people are okay waiting. Some people want to know the answer tomorrow. And then for the patients who are higher risk or for a procedure, then we would consider waiting and just getting a repeat CAT scan and following closely. Other people would do a biopsy straight away. And so these are the kind of the different types of biopsies or management strategies from least invasive to more invasive. Obviously, if you don't do any procedure and just monitor it, it's not very invasive. All the way up to kind of taking the thing out, which obviously is major surgery. What we do as pulmonologists is kind of that middle ground called a bronchoscopy and bronchoscopy assisted biopsy. It's not too invasive, which we'll talk about, but it does require anesthesia. Similarly, so it's primarily a diagnostic procedure. It's a scope. So if you've had a scope before, like a colonoscopy or a scope in your stomach, it's very similar to that. It's an outpatient procedure. You are put to sleep through it, and you get to go home after. You can't drive home. You have someone come with you, but you can definitely go home. And what do we biopsy? We biopsy the spot, but we also want to try to biopsy the lymph nodes that are in the center of the chest. This is one picture of all the different lymph nodes that are in the center of the chest that we want to make sure either does or does not have cancer on it if we decide to do a biopsy. The reason why we do this is because that determines what stage of cancer it is, if it is cancer. The more lymph nodes that are affected by cancer, the higher the stage, and unfortunately, less options for treatment you have. And so, as you can see from this table, it's very complicated. And so from the bottom line is, from your perspective, just so you know that what we biopsy is both the nodule and likely we also biopsy the lymph nodes to get a better idea of where, if you have lung cancer, the degree which has had spread anywhere else. Now, here in Mount Carmel, we recently got what's called a robotic bronchoscopy. It's normally when we do a scope, we kind of hold it with our hands and kind of guide it with our hands. But this, we kind of take our hands off of it. It's actually attached to this machine here, and using a screen, we actually can move the scope kind of very nimbly into the very edges of the lung. And so it allows us to kind of get much, much smaller nodules than before we couldn't get with relatively high degree of certainty. And this is kind of sort of what it looks like. It's sort of like a GPS, kind of your Google Maps of the lung, allows us to kind of navigate to wherever we need to go to, and then take a biopsy of it. So before we were using, like, I don't know if people remember the AAA maps. That's what we were using before, and this is like a kind of a much better and more like Google Maps. And the risks of this procedure is pretty low. The two main risks is something called a collapsed lung, which happens, if you look at the literature, about 5% of the time. The other option to do a biopsy is to stick a needle from the outside in, which you can imagine sticking a needle into your lungs has a higher risk profile. So the risks of a collapsed lung is somewhere around 10%, 10 to 25%, depending on where you look. And the risk for bleeding, again, is very low, so at 3 to 5%, which is in line with other types of bronchoscopic or lung scope procedures we do. So if you want to find out your risk for lung cancer, we have this health assessment, risk assessment from the Mayo Clinic. We have a QR code that you can scan. And, if you have like a higher risk, or if the assessment feels that you have a higher risk, we would strongly urge you talk to your primary care doctor about it, or potentially schedule it with a lung doctor to kind of look into it more to see if you would be a candidate for lung cancer screening. And I think this is also, if you want to make an appointment with us, this is also a QR code for that. And we have a number there as well. So
yeah, go ahead, Shri.
Oh yeah, so I just want to leave some time for questions. So I want to make sure I give you guys enough time to think about any questions you have, and so we can have a little bit of a discussion.
Yeah, this is, as you guys can tell, we're very passionate about taking care of our patients, and prevention is our goal, and early detection is our goal. And if you have any questions, this QR code can help in getting you an appointment with one of our team members, and we'll do our best to take care of you and your family members. There's a question. First question is, if I'm over the age of 55, do I need to have a screening every year?
So yeah, so when they looked at that trial and that data, you get the benefit mainly for if you get a screening every year until from 55 to, in that case, 74. Because obviously you don't want to stop screening before that time, because potentially you can miss a spot. So similarly, like how you get a colonoscopy every 5 to 10 years, depending on what they find, you would need to get a CAT scan every year if you meet that criteria. Now, sometimes if the other caveat to that is if you've quit smoking a long time ago, and it's either, then you kind of can stop it a little bit earlier if you've been less than 15 years, or if you've quit smoking more than 15 years.
One thing about screening in the age of 55, that criteria is mostly for patients that are smokers. There are family members and patients that are at risk for lung cancer that do not smoke based on history and genetics. If you feel that lung cancer is in your family, especially non-smokers, and you would like to discuss your risks with a pulmonologist, that is also an option. Yeah, the screening trials were all focused on smokers, but there are lung cancers that are growing in non-smokers. The next question is, which type of CT is better?
So for screening purposes, the only CT scan you need I guess it's sufficient, is a low dose chest CT. Now, any chest CT scan will suffice. But again, these are patients who are asymptomatic, right? So they don't have any symptoms, and you're just coming in for screening just for your annual health checkup with your regular doctor. If you have symptoms of something going on, like coughing up blood or something like that, that's a little bit different, and maybe you would get a regular CT scan in that case. But for purely screening purposes, you're just going in for your annual checkup, a low dose chest CT would be sufficient.
And if that low dose chest CT, for example, finds a very small spot, a nodule in your lungs, we follow certain criteria whether we should actually repeat a scan sooner or wait to have another screening CT in 1 year. So we follow very stringent criteria for that. Our next question, if lung cancer runs in my family, is there a specific age I should get screened?
And I think, unfortunately, we don't have a lot of data to support specific age cutoffs for non-smokers who are for screening. I think this is more of a case-by-case basis of how early your family members have gotten lung cancer. They're, if your family members have others, were they smokers, were they non-smokers, what age they got cancer. So those types of things play into it. I don't know if you have any other thoughts, but I don't think there's any
Yeah,
specific guidelines to kind of
yeah,
for
there really,
non-smokers.
I agree. There's no specific guidelines, but we go case by case in patients with a significant history of cancers in their family and lung cancers, and look at the age the cancer started showing up in the family, and making decisions and looking at your own personal risk factors. Did you smoke in addition to having a family history of lung cancer that was in a non-smoker? And sometimes, if there are multiple family members that are have lung cancer, that are non-smokers, we would sometimes make recommendations, meeting with a geneticist, to look at risk factors. Are there any other mutations that are running in the family or genes that could put you at risk for lung cancer? So
So I think,
that's kind of our approach.
yeah, so I think bottom line is if you have family history of lung cancer, you should bring it up with your primary care doctor
Yeah,
and or your pulmonologist.
yeah. The next question, for the 5-year survival rate as less than 25%, would you say that a contributing factor to that is that patients continue to smoke, use nicotine, or would you say it is because of the type of cancer itself?
So I think it's probably maybe the type of cancer, but I think predominantly it's because we're catching these people late, right? So the 5-year survival is for everybody who has lung cancer, right? And so if you catch lung cancer later in its course, you're unfortunately more likely to die from it sooner. So the risk of dying from early stage lung cancer, let's say, so they just found a spot and it's you get it resected out or cut it out, is somewhere between 80 to 90% for 5-year survival, right? But we're only catching a small percentage of those people. We're more commonly, unfortunately, in Ohio, catching people much later in the course. So I think some of it is the type of cancer. Some of it is we are catching people later. And this is why we're stressing the importance of lung cancer screening, because if you catch these things early, oftentimes they're sometimes curative, and at the very least, your survival is much higher. As far as like continuing smoking, it's not helping because obviously if you're continuing smoking, you're increasing your risk for other comorbidities, which also play into role of how well you will tolerate treatment. So that also is not helping. But I would say the predominant reason is we're catching people late and potentially the type of cancer.
Yeah, Dr. Shree answered this, in a very methodical fashion. I think, all our patients that get diagnosed with cancer that are still smoking, we get a very common question is, doctor, I have cancer, why would I stop? And it does, as he said, affect your treatment. It does affect your health. It does affect how you respond to treatment for your cancer. So we work with our patients in a very stressful time, on smoking cessation. Sometimes we help with getting them to smoking cessation counseling, because it really is crucial to take away that trigger. Our next question is, do I need a referral to receive a screening?
No, I think your primary care doctor can order the screening CT scan if he or she feels you've met the criteria, either from guideline-based practice or just based on your specific family history, you don't necessarily need a referral. Obviously, if you want to talk to a pulmonologist, you're always welcome to make an appointment with us to talk to a specialist, but you don't necessarily need to see a specialist to go get a lung cancer screening CT.
Yeah, primary care is crucial to be involved in this. And again, if you feel that you're not getting the response you need, you feel that you need more answers, then we are more than happy to be involved as a team in your care. And getting an appointment or a referral to see us, we can help facilitate screening. But it's very easy for primary care to, for smokers to order screening. And I think there's a question about, are you able to share slides? And I definitely think we can share the slides for this. And we'll reach out to our IT team and get these slides over to whoever wishes to see them. Our next question, does treatment include chemo or is it just removal of the nodule?
So, so I'm not an oncologist, although I actually am married to an oncologist, so it depends on the type of cancer, and the predominant question we all have to answer is the stage, right? So the goal is that you don't need anything like chemotherapy, or in these days, what's called immunotherapy. If it's just a spot, and it's a small spot, and it is cancer, a lot of times you can get away with just doing surgery with no additional treatment. As the stage of the cancer is higher, or it's either a bigger spot or it's spread to lymph nodes, then the likelihood that you will need systemic therapy, which means either chemotherapy or immunotherapy or a pill, is much higher. And so that's why what's called staging the lung cancer is so important, because that really does affect the treatment. In addition to the type of cancer, which also will determine whether you need chemotherapy or not. So I think the two questions you have to answer is if it's spread or not, and the type of cancer, and that will determine whether you need chemotherapy.
And there's have been a lot of advancements in the treatment of cancer. So some patients may need treatment that doesn't include surgery, but is not chemotherapy. We will look at the specimens through pathology and testing and through our oncology team members and look for sensitivities and targets in mutations in the cancer, to where some patients may just need their immune system to fight cancer. Some may need to target a specific mutation. So the advancements in lung cancer treatment do not include just chemotherapy or surgery. They include other treatments that are not chemotherapy. Our next, once cancer is confirmed with biopsy, do you refer a patient out to oncology or treat yourself?
So typically what happens once we get a biopsy and it turns out to be positive, what the next steps are. The next steps would be typically here at Mount Carmel and most places, what we do is we talk about your case at what's called a tumor board, which includes oncologists, radiologists, surgeons, to try to figure out what the next best steps in your treatment plan would be. And then oftentimes we would then, once we figure it out as a team, a multidisciplinary team, what the best option is, we would then refer you out to whoever you need to see. Typically, it does include an oncologist, but it also could include a surgeon. It could include what's called a radiation oncologist, the doctors who give radiation. And so the next steps, which is I think what your question is to what's the next step after we get a positive or a confirmatory biopsy for cancer, is we talk about your case. So, and we as a multidisciplinary team try to figure out who the next best person for you would be. That could include oncologists, but it could include other team members as well.
How much does secondhand smoke exposure affect your risk of developing lung cancer?
So I think the there is data showing that it does increase your risk. It probably depends on the type of secondhand smoke exposure. It's probably not as it for sure it's probably not as bad as actually smoking. It probably does increase your risk slightly, but not to the degree of actually smoking. So it is a risk factor. So I think it's something that's important to disclose to your doctor. But it's probably not as high as actually smoking.
Is there a danger to smoking marijuana in regards to lung cancer?
So with marijuana, I think again the data is a little bit less clear with marijuana because it's so variable compared to smoking. Again, it probably does increase your risk slightly, but not to the degree of like nicotine cigarettes do.
Yeah. With marijuana, it's not just, the effect of the marijuana, you're getting the effect of whatever you're inhaling in addition to the marijuana. So, when you're using marijuana, I think you have to consider what other toxins you're inhaling when you smoke or inhale marijuana. And that could make your risk worse, but as Dr. Shri says, it's a little different than cigarette smoking. And the next question is very good question also. These are all amazing questions. My house I lived in for 25 years tested high for radon. Do I need a screening or at age over 55?
So with radon, if you, the literature is a little bit conflicted about that. I think some data shows that it's probably a significant. It does increase your risk for lung cancer, but this is a situation where we kind of have to go on a case-by-case basis. If that's your only risk factor, this is where a discussion with you and your doctor needs to happen. It's not as potent a risk as smoking is. It probably also depends on the level of radon it's in your home and how high it is. The CDC actually has a great website reference on it. We can try to give you that link. But again, this is where we have to talk about other types of risk factors. I think if it's only radon, I think it's this is something where we would have to discuss with you. It's not necessarily guideline based, but based if you had radon plus other risk factors, I would consider screening for you.
Yeah. And we also have to look at if there are patients that do not fit into these guidelines for us as physicians, but have risks. And sometimes insurances don't cover for the screening. And we take that into consideration, but also have a risk benefit discussion with our patients on if we think the benefit is to screen them. And then what options do they have if insurances do not cover it? And I think that's the important discussion of the patient-physician relationship and going through not just ordering the scan, but is the scan covered? And then the benefits of getting the scan and the risks of getting repeated scans. Once you enter screening, it's not just one scan. We're talking about annual scans. And that's crucial for our patients to understand. Any more questions that we can answer for our attendees? Well, thank you guys very much for your interest. We have a passionate team. We're passionate about lung cancer. We're passionate about lung cancer prevention and early diagnosis. And we are available to you. If there are any questions, please reach out to our office. And we will do our best to get you in to have a discussion with one of our pulmonologists and what the best next steps are. We will make ourselves as available to you as needed. Thank you guys very much.
Thank you. And then I'll be putting